Hello and welcome to SRG Medicine. Today, in this Respiratory Medicine Series, we shall be concluding our topic on an approach to patient with cough. So, the contents of this video are diagnosis of acute cough, diagnosis of chronic cough, then treatment of acute cough, and finally treatment of chronic cough under two headings, that is, general outlines and specific drug therapy. After that, we'll be concluding the video with a summary. So let's start. So, diagnosis of acute cough. So we can diagnose acute cough based on different tests. So the first thing that we have to remember over here for diagnosing acute cough is there can be four main reasons for, or four main causes of acute cough. So based on the similar type, we can classify it. So firstly, on diagnosing acute cough, the first and foremost important part would be history, along with physical examination. That will give us a clue to which of the four underlying cause might be the cause of acute cough. So that might be infection. So if it is infection, then it is suggested by few signs, which might be fever, raised erythrocyte sedimentation rate, increased C-reactive protein value in serum, increased leukocytosis, and if there is signs of infections, then we have to perform specific investigations. For example, we can do sputum culture, we can do biopsy, or if there are signs of anaerobic infection on sputum, then we could start with antibiotic. So there can be specific investigation afterward, followed by the general history and physical examination. So the other cause can be allergy. Allergy can be manifested as, the first thing that we need to note in allergy is there's always a history of exposure. The patient is usually allergic to something and is exposed to that same particular thing or allergen, or sometimes the patient might not know that he or she is allergic to something, but has an history of exposure to an allergen. And presence with the signs of facial flushing, redness, or periorbital edema, dyspnea, tachypnea, and other signs such as skin reactions. And that's how we diagnose allergy as a cause of acute cough. Now, for diagnosing the foreign body as a cause of acute cough, we have to see initially there must be a history of some ingested foreign particle, or sometimes this can be missed. But we can see by the general appearance of the patient. The patient appears choked. What I mean by choked is the patient's face may be cyanosed or might be reddish in color, along with distension of the facial veins and neck veins. Not only that, but there might also be sudden onset of tachypnea, dyspnea, and a desire to gasp or wanting for more air, that is air hunger. And another thing is, if we see such kind of presentation in a patient, then the first thing that we have to do is order a chest x-ray immediately. And by using chest x-ray, we can localize where a particular foreign body is placed, such that we can perform further treatments. So the next thing that we would like to do is bronchoscopy. If the object is radiolucent, that is, object cannot be seen on x-ray, then bronchoscopy is the preferred method for diagnosing foreign body. Now the next thing would be chronic cough. Here are a few pointers which point towards chronic cough, which include hemoptysis, systemic illness, and suspicions of neoplasia. However, any cause of chronic cough at their onset might begin as an acute cough, so we might not know. That is, if we have ruled out infection, allergy, and foreign body, we need to check for whether there are any other chronic causes, so that needs follow. So these are the examples. Now this is a typical appearance of a choked face, that is due to foreign body ingestion. The person's lips look cyanosed, even the tongue looks cyanosed, and the person seems to be gasping for air. So that is a choked appearance. And the next thing that we would like to see is allergic reaction or allergic manifestation. That is, you can note here the periorbital edema, redness on the cheeks, and there are also some swelling on the forehead. So that is shown in allergic manifestation. Now let's move on to the diagnosis of chronic cough. So how do we diagnose chronic cough? Here, I have based this slide on the guidelines based on British Thoracic Society. However, based on your region or locality, the guidelines might be different. So, for diagnosing chronic cough, first thing, so as with all the diagnosis or diagnosis of anything, first thing that we have to do is take a detailed history and perform physical examination. After that, after performing physical examination in chronic cough, we have to perform chest X-ray and spirometry. Note that spirometry is performed only if the person or the patient is greater than 5 years old. So these, after history, physical examination, chest X-ray and spirometry, if the cause is highly indicative, then we further evaluate and confirm the cause and then treat the cause. However, if the cause is non-suggestive, that is, if the results of history, physical examination, chest X-ray and spirometry are non-suggestive, then we need to refer them to a respiratory physician. Now, what does a respiratory physician do? So, after referring to respiratory physician, the first thing that respiratory physician does is perform bronchoscopy. Usually, a respiratory physician, which is usually a super specialist, does flexible bronchoscopy. However, rigid bronchoscopy can also be performed, and they are usually done suspecting foreign body. So, if after X-ray, spirometry, and bronchoscopy, furthermore, the results are non-conclusive, even after X-ray, spirometry, and bronchoscopy, everything is normal, there is no suggestive cause, then we do high-resolution CT of thorax. Then, if even high-resolution CT of thorax doesn't reveal anything, then we have to perform specific investigation based on the risk factor of patient, which includes bronchoprovocation testing, 24-hour esophageal pH monitoring, barium esophageogram, endoscopy, sinus imaging, electrocardiogram, and induced sputum testing. So this was about diagnosis of acute as well as chronic cough. Now, here's a quotation that I would like to keep here. That is, pressure on nerve causes irritation and tension with deranged function as a result. So why not release the pressure? Why not cause? Why not adjust the cause instead of treating the effects? Why not? So, in any kind of treatment, our first and foremost goal would be to treat the cause rather than treating the symptoms. So, let's start with acute cough. So, for treating acute cough, there can be different conditions, as we have said. There can be four main causes for acute cough. The first one being infection. So, if it's infection, then it is usually self-limiting and rarely needs medical intervention. However, if the infection is bacterial, then we need to start antibiotic treatment. Now, for allergy, simple removal of allergen can lead to subsidation of cough. However, sometimes the allergy is very much severe and needs medical management, which includes antihistamine, adrenaline, steroids, bronchodilators, IV fluids, and furthermore other management of allergy. Now, the next thing we could be looking for is if there is foreign body, then bronchoscopy is the treatment of choice, whether it be flexible or rigid bronchoscopy. This is because bronchoscopy can be used both for diagnosis as well as treatment. Now, the next thing is if the cause is unknown, if the cause of acute cough is unknown, then it is usually self-limiting and rarely needs medical intervention. However, it benefits from over-the-counter preparations. There are various over-the-counter preparations present in market, and they help. Also, homemade therapies such as steam inhalation, warm honey syrup, baked ginger, or any other kind of home therapies present in your locality based on your culture, your norms and religion, they might differ. But the main trick over here is all of these. A research paper has shown that OTC preparation and homemade therapy give benefit to the patient with acute cough because of simple voluntary suppression. That is due to a placebo effect. Research are going on further in this field, but till now it has been revealed that it is due to a placebo effect. Now the next thing is, if we have to give drugs to the patient with acute cough, then the drugs would be dextromethorphan, menthol, or first generation antihistamines, which includes chlorpheniramine, diphenhydramine, and others as well. But we should not give opiates to a patient with acute cough. Opiates include codeine, folcodeine. So opiates must not be given in acute cough. The next thing that we will talk about is treatment of chronic cough. So we'll start with the general outline. So how do we treat chronic cough? So after diagnosing the chronic cough, if we know what is the cause, then after knowing the cause, we have to determine whether the cause is treatable or non-treatable. If the cause is treatable, then our main target would be to treat the cause. And once we treat the cause, the symptoms of cough will itself subside. But if the cause is non-treatable, for example, in cases of extensive metastasis of lung tumor, then we have to determine whether the cough is productive cough or non-productive cough. If the cough is productive cough, then we have to use expectorants, and if it is non-productive, we have to use demulcents or antitussives. Now the next thing here is, if the cause is unknown, that is idiopathic chronic cough. After the extensive diagnosis also, we haven't known what's the cause of chronic cough. Then in such condition, we have to determine whether the cough is productive or non-productive. And on similar basis, we could give either expectorants or, if non-productive, then demulcents and antitussives. Now, we will move on to the from general outlines to the specific drug treatment. But before that, I'd like to show where the drugs act and what are they named as. As we can remember, we had studied about a reflex arc of cough. Now we'll plot the drugs on the same reflex arc. So the first thing was a stimulus inciting stimulus will cause stimulation of a receptor. So drugs that act to stop the stimulus acting on the receptor and to stop the stimulation of receptor are known as demulcents. So a group of drug which prevents the stimulation of receptors are known as demulcents. Now, after that, there will be afferent nerve, which will take impulse to cough center, and there are also higher center influencing the cough center. So, and after that, the impulse would go to efferent nerve. So, the group of drugs that act either by suppressing the higher center modulation of cough center or directly in the cough center itself are known as antitussives. So, after that, we talk about efferent nerve, then it goes to effector organs, and ultimately cough is elicited. So the group of drugs which help in expectoration of the sputum is known as mucolytic. So it helps in making the cough reflex effective. So let's move on to the individual drug therapy. So the first group that I'd like to talk about is demulcents, which acts by forming a soothing film over the mucous membrane, thereby decreasing the receptor firing, that is, decreasing the afferent impulses for cough. It includes various kinds of over-the-counter lozenges, syrups, linctuses, glycerin, etc. These are most commonly found in markets. Now the next thing is antitussives. We can group antitussives based on 4 categories, which includes opioids. Now the opioid group includes codeine and folcodeine. Now the action of opioids are blocked by naloxone, which act competitively on mu and kappa opioid receptor. But the thing here is that unlike morphine, these drugs, that is the opioids used for cough, that is codeine and folcodeine, have a low abuse liability. And not only that, but their side effects are mainly constipation and drowsiness, while respiratory depression due to codeine or folcodeine is rarer in the cases of normal doses given for cough. They are contraindicated in children and the patient with low respiratory reserve. For example, the patients with COPD, asthma, or any other kind of lung pathology. Now, talking about non-opioids. So the next group would be non-opioids, and they include noscapine, dextromethorphan. Now, they are equivalent to codeine in their action, whether it be in the term of efficacy or potency. And the peculiar character here is that they are not blocked by naloxone. So they act by some unknown receptors on the cuff receptor, not by opioid receptors. The next thing is that their most common adverse effect is dizziness and nausea, and they are preferred to use in spasmodic cough. So they can also cause bronchoconstriction in asthmatic, and this is a relative contraindication in cases of asthmatic patient. So in asthmatic patient, we must give noscapine or dextromethorphan only with specific care or monitoring. The next group of drugs that we would like to talk about is antihistamines. These include first-generation antihistamines, or also known as sedative antihistamines, which include diphenhydramine and chlorpheniramine. These act due to their sedative as well as anticholinergic action, and they are morally preferred in allergic cough. But the point to be noted here is that though asthma is a hypersensitivity phenomenon, but antihistamine does not act on asthma, but acts on other kinds of allergic cough. So their common adverse effects are drowsiness, dizziness, and anxiety. So they are preferably given during night, but not during day. The next group that I'd like to talk about is peripherally acting antitussives, which include prenoxidazine. So they act by desensitizing the stretch receptor, so that they act at the receptor level. And they are usually preferred for the cough of bronchial origin, which includes bronchiectasis, COPD, acute bronchitis, chronic bronchitis, etc. Now talking about the last group of drugs, that is mucolytics. So mucolytics includes the drugs ambroxol, bromhexine, carbocisteine, and acetylcysteine. Ambroxol and bromhexine acts by depolymerizing the mucopolysaccharides, which are present in the mucus or in the sputum, and they also act by increasing the mucociliary clearance, thus helping to expectorate or take out the secretion of respiratory tract. So they are most commonly useful in mucus plug formation situation. For example, in the cases of allergic bronchopulmonary aspergillosis or asthma or bronchiolitis obliterans. But their common adverse effects include rhinorrhea, lacrimation, nausea, and hypersensitivity. So the next drugs that we will be talking about is carbocysteine and acetylcysteine. They act by breaking disulfide bonds in the mucoproteins. So in the mucoproteins, the mucoprotein are linked by various disulfide bonds. And carbocysteine and acetylcysteine act by breaking those disulfide bonds, thereby causing decrease in the viscosity of mucus, thus helping to clear out the mucus. Now, the thing to be noted here is that acetylcysteine must be given directly into respiratory, whether it be by inhalation or nebulization. However, carbocysteine is given orally. And the contraindication of carbocysteine is to the patient with peptic ulcer disease. Now, I've here mentioned some other drugs such as squil, guafencine, and ipecacuanha. Now, these are expectorants, that is, they help to take out the sputum by increasing the cough, and they are not used nowadays because of their toxic potential. So it is not worth mentioning in this video. So these are my references. Hope you liked my video till now. Hope you enjoyed it. Stay well, stay good. Thank you. And please do comment whatever your suggestion or any kind of questions do you have. Please do comment. Thank you.